Okay guys, so in this video we will be revising ophthalmology with the high-yielding point, the most important things that are there for your exam, and the important image, and most important the fundus guys, fundus images, which I have named it fundus ka funda, that helps you easily identify the fundus finding guys. Okay, so let's get started guys. See, first of all, whenever we are talking about a structure, we should know how it's formed guys. So if we talk about the eye guys, remember endoderm does not form any part of the eye guys. So if in an option endoderm is there, straight out rule out guys, endoderm, none of the part of eye is formed by endoderm guys. Now coming on to the ectoderm guys, there are two types, surface ectoderm and the neuroectoderm guys. Then there is mesoderm and there is the neural crest cells guys. Okay, so remember surface ectoderm. If you think about the surface guys, what all structures are there on the surface guys? So you have guys lens, okay, and there is epithelium of cornea and conjunctiva guys. So remember, these are the most important thing you need to remember for surface ectoderm. Now coming to the neuroectoderm. Ectoderm, you know that ectoderm only suggests that it is epithelial tissue. So now this forms the epithelial tissue of the iris and the ciliary body guys. Okay, and neuro means it forms the retina, optic nerve and the muscles of the iris guys. Remember this. Okay, now coming on to the mesoderm guys. Okay, so if you think of the mesoderm is basically the connective tissue formation. So it will form the muscles guys. Okay, so it will form the extraocular muscle. You know, there are superior rectus, inferior rectus, obliques. Okay, so these muscles are formed by the mesodermal origin. Okay, now coming on to the neural crest guys. So how will you remember neural crest? CRES, that is cornea, and which part of the cornea? Stroma and the endothelium guys. CR for cornea, E for the endothelium, S for the stroma, then again S for the sclera and T for the trabecular mesova guys. Okay, now the neural part, it will form the meninges of the optic nerve guys, because neuroectoderm has already formed the retina and the optic nerve guys. So meninges will be formed by neural crest cell. Also this form guys, see also with the help of C you can remember that it is ciliary muscles and the ciliary ganglion guys. Okay, so the question may be asked, muscles of the iris are formed by. Okay guys, so this is one of the most important height where you get confused. Muscles of the iris are formed by the neuroectoderm guys, not by the mesoderm. So think wisely before answering. Now someone has lens. Okay, think lens is a outside structure, surface structure, hence formed by surface ectoderm. Now think someone asks you ciliary ganglion. Okay, so this is a part of neural crest. C comes there. So ciliary ganglion is formed by the neural crest guys. Okay, so think once before answering guys. Okay, now moving on to the next topic guys. Okay, so see, in this topic I have named it as a fundus ka funda guys. Okay, so that what is the funda, what should you think in order to identify the image, what is that key point that will help you to identify this fundus ka image guys. Okay, so see, how will you identify the artery and vein guys. Okay, the one that look darker guys, okay, is actually the guys, the one which look darker is actually the vein. Why? Because they contain deoxygenated blood guys. And the one which looks lighter guys is actually guys artery. Okay, because it contains oxygenated blood guys. So remember, first of all we should know to identify which side this picture is given guys. So always look at the optic disc. See, in this photo if you look, optic disc is to the left side, hence this is the image of guys left eye. Okay, so this is must know thing here guys. Okay, so see, now we'll talk about the various finding guys, what does it change and not change. Before that I would tell about the instrument that help you to look visualize at the fundus guys. Okay, so see, first of all is this instrument where you see a doctor wearing an instrument and taking a help of lens in his hand and viewing the eye guys. Okay, so this is indirect ophthalmoscope guys. So what do you need to remember in indirect ophthalmoscopes guys? Okay, so indirect ophthalmoscope guys, it has a magnifying of 8 disc diameter. Remember guys, 1 disc diameter guys is equal to 1.5 mm. Okay guys, so if you talk about guys ki 8 disc diameter, that is 12 mm guys, means it can visualize up to 12 mm guys. Okay, so this visualize a larger area guys. Okay, so when you are trying to visualize a long distance guys, magnification achieved will be less guys. So it has a magnification of only 5x guys. Okay, and see, so if you visualize a larger area, peripheral retina is also visible. And what is the characteristic of the image? It is real and inverted image guys. Okay, this is real and inverted image guys, which is 5 times magnified guys. Okay, so how can you remember? Indirect, remember like Rin, you know, there is a company knows as Rin which makes soap and other thing. So real and inverted guys, okay, is indirect ophthalmoscope. Okay guys, so I think you won't forget this. Real and inverted is indirect guys. Okay, now coming on to the other instrument, that is direct ophthalmoscope. This is a handheld device guys. Okay, if you might have visited ophthalmoscope for a prescription for a spectacles, you might have seen him using this instrument, guys. Okay, so see, this goes up till a 2 disc diameter, guys. Okay, there it was to 8 disc diameter, guys. So how can you remember? Direct, that is D. So D can be make D looks like a 2. Okay, or also how can you remember indirect, guys? Indirect is a 8 letter, guys. Okay, hence this visualizes up to 8 disc diameter, guys. Okay, and direct is 2 disc diameter. Okay, guys. See, that is, it can visualize up to 3 mm. Means it is visualizing, guys, very less distance, guys. Means magnification will be more, guys. So this gives you a magnification of 15 times, guys. Okay, and how is the image form? That is erect and virtual. How do you remember? Direct is erect and virtual. Remember, they 15. Okay, that at least like most of the people like goes to temple, like college student, like once or twice in a month. So like in every 15 days you are visiting Dev, a god, something like this. So erect and virtual, that is 15 times magnified, guys. Okay, see, so basically this is only the same thing which I said, guys. Okay, now coming on to the normal fundus, guys. I said, see, so this is the part where the nerves and all vessels arise from the optic disc, guys. Okay, see, this is the optic disc. Now think, where is the optic disc, guys, in this image? This is on the, guys, right side, hence this is the right side fundus, and here it is on the left side, guys, hence it is the left side fundus, guys. Now coming on to this optic disc. This optic disc is a 1 disc diameter structure, means 1.5 mm, because I said 1 disc diameter is equal to 1.5 mm, guys. So see, if you look at the normal optic disc, guys, try to identify. This is slightly pinkish. Do you find the pinkish hue here, guys? And it is located on the nasal side. I said that identify the nasal side. Where is the optic disc? That is the nasal side. Then it means the other side would be the temporal side, guys. Okay, then identify the artery and vein, as I said. Okay, vein will be darker and artery will be lighter, guys. Then this part, the centermost part, is the macula, the central part of the retina, guys. Okay, and it is 5.5 mm, guys. Okay, and see, now coming on, guys, to the distance between these two, guys. Okay, this optic disc and the macula, that is 2 disc diameter, guys, that is 3 mm. Okay, so this may be asked as an image based question, guys. Now coming on to the detail of macula, guys. Okay, so this macula was 5.5 mm, guys. Okay, and the centermost part, which has the sharpest image, guys. Okay, this is known as the fovea centralis. Okay, see, why the name fovea centralis? Because the cones are maximum concentrated here. Why, guys? And you might have remembered in your past class that cones are responsible for, guys, they are responsible for bright light. And what are responsible for, guys, dim light? They are the rods, guys. Okay, so see, the centermost part of the fovea centralis, that was 1.5 mm. That is foviola, guys. Okay, and that is actually 0.5 mm. Okay, and if you shine the light, normally you see the foveolar reflex present if the fundus is normal, guys. Okay, so this was all about the normal fundus that we need to talk, guys. Okay, then there is a rule, guys, that is, then there is a normal cup to disc ratio, guys, that is normally 0.5 to 0.6. remember that there is an increase in cup to disc ratio in glaucoma, guys. Why? Because this neuroretinal rim, guys, this gets thinned out, guys. Okay, so see, there is a rule for this neuroretinal rim thinning out, that is known as isn't rule, guys. Okay, so isn't means I means inferior, S means superior field, N means nasal, and T means temporal. Means inferior is the first to affected, followed by superior, followed by nasal, or followed by temporal. Now someone asks you which is the last field to be affected. Remember, isn't rule, T comes at the end, that is temporal is the last to be affected, guys. Okay, see, now coming on to the important fundus finding that you may see in the image, guys. Okay, first of all, this is a case, first of all is a myopia. So what does myopia means? Myopia means, guys, short-sightedness. So what happens in myopia, guys? Like most of the people have myopia, guys. Okay, that we are not able to see far object, guys. There is no problem in seeing nearby object, but problem with seeing far object, guys. Okay, so this is myopia. So what is the findings that we see? Okay, see, I'll tell you the finding. First of all, there are lacquer cracks. If you look at the fundus, guys, okay, don't feel like that there is retinal hemorrhage, guys, and there is cracks all around the retina, guys. Okay, so this is lacquer cracks. You can remember lacquer cracks as a lava, guys. Okay, this looks like a molten lava, you can see in the image, guys. Okay, see, then in the next image, guys, okay, now there is what happens, there is a checkered appearance of the fundus, guys. Okay, if you look like the body of the tiger, guys, so there is dark light. Okay, so this is known as the tigroid fundus, guys. Okay, Then what happens that this myopia, it may cause posterior vitreous detachment. You can see the guys breaking of the ring. You can see that it's not continuous, it's breaking, guys. Okay, then there is regmatus retinal detachment, guys. When we talk about the guys retinal detachment, guys, there are three type of retinal detachment. Okay, that is the regmatus retinal detachment, guys. Okay, then you have the guys tractional retinal detachment, and you have the serous retinal detachment. So what does regma? Regma means break, guys. Okay, so now think about the pathogenesis, guys. What happens? Okay, suppose there is a break in the retina, guys. Okay, suppose I created a break in the so suppose I created a break in the retina, guys. Okay, so suppose this is the vitreous fluid, guys. Okay, so what happens, guys, and this is the 10 layers of the retina. This is the first layer and this is the last layer, guys. Okay, so what happens, this fluid will now seep into the subretinal space, guys. So when this fluid seep into the subretinal space, okay, the inner 9 layers of the retina get separated from the retinal pigment epithelium. The 9 layers of retina together known as, guys, neurosensory retina. So there is a separation of neurosensory retina and the outer retinal pigment epithelium, and there the fluid accumulates. Okay, and myopia is one of the most common cause of, guys, regmatus retinal detachment, guys. Okay, so you understand why are we talking about regmatus finding here in myopia, guys. Okay, see, now coming on to the other fundus finding, that is congenital toxoplasma, guys. Okay, see, this looks like a punched out scar, guys. Okay, and the site of the lesion is the macula, guys. You can see optic disc is fine, it looks like purple, guys. There's no problem in the optic disc, and there is pigmented borders, guys, because of proliferation of retinal pigment epithelium, that is 10th. So see, congenital toxoplasma. So what do you find in congenital toxoplasma? Punched out lesion with pigmented border, guys. Okay, so remember, this is the pigmented border, guys. Okay, toxoplasma is pigmented border, and the problem is at, guys, where it is at the macula, guys. Okay, so be sure, guys, over there. Now coming on to the toxoplasma, guys. Okay, so this toxoplasma, it looks like a headlight in fog appearance, guys. Remember when you are driving in the snow in the morning, guys, what happens? You are not able to see the nearby object, so you're on the headlight. Okay, so this is basically headlight in fog appearance, guys. Okay, and this toxoplasma is the most common cause of, guys, posterior uveitis. Okay, so now coming on to the sarcoidosis. You know that sarcoidosis is basically a multi-system disorder, guys. So what happens in sarcoidosis? It involves multi-system organs, so it involves eye also. So there are inflammatory exudates that cause inflammation of the vessels. Okay, so see, if you look it, what does it look like? It looks like all the way there is candle wax spread around. Okay, or like maybe you can think it as like a crackers are spread about when the cracker goes in the sky, guys. Okay, so this looks like a candle wax dripping, guys, seen in sarcoidosis, guys. Okay, see, now coming on to the CMV chorioretinitis. So how have I remembered CMV chorioretinitis? CMV I have remembered like chalo mall. Okay, when you go to mall, what happened, guys? You ask your parents to buy you a pizza, or you may ask more cheese, sauce. Okay, so this happens everyone. So this looks like a pizza pie or sauce appearance. You can see the photo, guys. Okay, so when you go to the mall, that is chalo mall, so you will ask for bush fire pizza. Nowadays fire pizzas are very popular, guys. Sauce and cheese appearance, guys. Okay, then is the sympathetic ophthalmia. You can see the Dallin first nodules, guys. Okay, see, these are the small nodules that you see all around, guys. Okay, so basically these are the cells between the retinal pigment epithelium and the Bruch membrane, guys. And where do you see this? This is seen in Vogt-Koyanagi-Harada syndrome and sympathetic ophthalmia, guys. Okay, so if you see multiple nodules, guys, in the choroid, that is sympathetic ophthalmia, guys. Now coming on to the Vogt-Koyanagi-Harada syndrome, guys. Okay, so how does it look like? This looks like a sunset appearance of the fundus. You might have remembered that, guys, like most of us plan to go beach in the morning or in the sunset. Why? Because it looks so beautiful. See, the image looks so pretty, guys. So this is basically a sunset glow appearance of the fundus that is seen in VKH syndrome, Vogt-Koyanagi-Harada syndrome. Okay, so this is basically a vacation wala syndrome, guys. Okay, so in vacation you go for a beach to have enjoy the party, vacation, kayaking. Remember, like this, guys. Okay, in the evening you are riding a kayak when you are on a vacation, guys. Okay, so this looks like a sunset glow of the fundus, guys. Now coming on to the choroidal melanoma. So remember, guys, melanoma, that is more of melanin pigment. So melanin is responsible for color. You can see the image looks darker in color. So this is the choroidal melanoma, is the most common malignant intraocular tumor in adults, guys. Okay, so this is the MCQ, guys. Okay, Now coming on to the next one, see here you see optic disc is completely fine, guys. Okay, and what did I say at the macula? Macula is slightly pale, guys. Okay, slightly pinkish, but here it looks more of a pinkish, guys. What does it say? This suggests that it looks like a cherry spot, guys. Okay, so this is known as cherry red spot, guys. When you think about the cherry red spot, guys, okay, so the mnemonic is cherry trees never grow old in sand. Okay, so C is for central artery occlusion disease. Then trees for Tay-Sachs disease, where there is a deficiency of hexosaminidase, guys. Okay, never is Niemann-Pick disease, guys. Then you have blunt trauma, that is Berlin's edema, also known as commotio retina, guys. Okay, see, this is an intracellular retinal edema that occurs in blunt trauma. Then you have gangliosidosis, guys, and you have storage disorder, and you have also have Sandhoff disease, guys. Okay, so remember cherry trees never grow old in sand and mud. Okay, guys, so this is the mnemonic for cherry red spot. And what do you see? You see in the macula, instead of being slightly pale, it appears more red, guys. You can see the finding, guys. Okay, so this is cherry red spot seen in CRAO, guys. Okay, now coming on, guys, to the this image, guys. See, you can find a similar finding. There is a pale fundus all around, guys. Do you see? And you find that at the site of macula it appears dark. Then think about why is the fundus filled? Central retinal arterial occlusion. Artery is occluded. Think. Then what happened? The blood will flow less, guys. When blood flow is less, the organ appears more white. Hence, this fundus also appear more white, guys. Okay, see, there is pale fundus, guys. Okay, what do you see here? And only macula is seen red, guys. Okay, and this is the mnemonic cherry trees never grow tall. That is central retinal artery decrease, Tay-Sachs disease, Niemann-Pick disease, Gaucher's disease, trauma, Sandhoff disease. You can now coming on to the, if there was a question of venous occlusion, that is central retin venous occlusion. So veins blood have gone, but they are not able to come out. Veins have occluded. What happened? There will be stasis of blood. Means it will appear much more red, just opposite to this. So if it appears much more red, that is like a splash tomato appearance. Like when you play Holi, like some of the people prefer throwing tomatoes on her. So he appears more red. Okay, so that is basically CRVO, guys. Okay, see, so basically in this photo I have seen CRAO, guys. Okay, there is a pale fundus, guys, you can see, and there is a cherry red spot at the macula, guys. Okay, when you see this image, guys, there is cattle truck appearance of the retinal vein. This is known as box carrying, guys. Okay, see, now this is basically a feature of atherosclerosis, guys. What happens in atherosclerosis, guys? So there are multiple plaques, guys. So these plaques get deposited, guys. Okay, so these are known as the cholesterol plaques, guys. Okay, and also known as the Hollenhorst plaque, guys, seen in arterial obstruction. Okay, now coming on, so this central retinal artery occlusion, CRAO, guys. Okay, it is the acute painless cause of illness. It is sudden and it is painless, guys. Now coming on to the CRVO, guys. Okay, so this is basically also acute painless loss of vision, guys. Okay, so what happens in CRVO, guys? Okay, so there is a release of when there is less of blood, there is a release of vascular endothelial growth factor. Okay, so this VEGF, what it causes? Neovascularization, guys. So you know neovascularization means the formation of new blood vessels that are leaky, as you have read in your path, guys. Okay, so when there is neovascularization of the eyes, it leads to at the angle, guys. Okay, this leads to secondary open angle glaucoma, guys. Okay, so this CRVO may proceed after 3 months to neovascular glaucoma, which is also known as 100 or 90 days glaucoma, guys. Okay, so this is important from MCQ aspect, guys. Now see, when you look this photo, what does it look like? Whole of the tomato has been splashed, guys. Okay, because of the stashes of blood. Okay, so this is known as tomato splash appearance, tomato blood thunder appearance, or tomato ketchup appearance. Remember, we have read one more pizza pie appearance that looks like a pizza. So when it was chalomol, that is CM, that is cytomegalovirus, guys. So there you find that, guys, pizza pie appearance. Okay, sauce and cheese appearance. Okay, see, so basically this images you see, this is the normal fundus finding, guys. Okay, see that this is the normal fundus, guys, because optic disc is pale and this macula is fine. Okay, see, now coming on to the cherry red spot, entire is pale and the macula is only red, guys, and this is CRVO, that is blood and thunder or tomato splash appearance, guys. Okay, see, now what happens that sometimes what happened around the optic disc, guys. Okay, where this nerve lay, there is cotton wool spot around the optic disc, guys, that is known as Prushner's retinopathy, guys. Okay, so this is important from MCQ aspect, guys. Okay, See, so this image I already talked about, that there is a pale retina, guys. There is a cherry red spot, and there is a cattle trucking or boxcar appearance, guys, due to segmentation of the vessel. Okay, so this cattle tracking, this pale retina, and this all are the findings of central retinal artery occlusion, guys. Okay, see. Now talking about the hypertensive retinopathy. So basically what happens, this occurs due to the hypertension, guys, this hypertensive retinopathy. So what do you find in a hypertensive retinopathy, guys? Okay, so this hypertensive retinopathy has certain grading, guys, which we need to remember this hypertensive retinopathy. Okay, so when we talk about the grading of hypertensive retinopathy, guys, okay, see, first of all, what are the findings? Then we'll think about the grading. Okay. See, you have a flame-shaped hemorrhage, guys, here in hypertensive retinopathy. You have hard exudates. You have cotton wool spots that are ill-defined, guys. You see, these are ill-defined cotton wool spots. And you have papilledema because the margins of the optic disc are not visualized. You can see, you cannot make out the margin, guys. Okay. So this stage of papilledema is a stage 4 of the classification, guys. Okay. See, we'll talk about the classification now. Okay, see, what is the classification in grade 1, guys? What do you see? We will find generalized arterial narrowing. Okay, I said about what happens, guys, that arterial attenuation takes place. I said the AV ratio decrease, guys. Okay, so arterial attenuation takes place in grade 1, guys. Now when you talk about the grade 2, guys, so normally what happens, it was 2:3, it comes down to 1:3, guys. Okay, now if you talk about the grade 2, guys, so what happens, guys, there is AV nipping, guys. Okay, means there is AV crossing, guys. So you find the presence of 3 signs, that is Salu sign, bonnet sign, and the gun sign. I'll show you all the sign in the form of image, guys. Then coming on to the grade 3, means grade 2 findings are present. Plus what do you find? You will find the flame-shaped hemorrhage, guys. Okay, you will find the cotton wool spots. Plus you will find, guys, hard exudates, guys. Okay, so all the finding that I showed in the image, that is the finding of grade 3. Plus if you find papilledema or silver copper wiring, how do you identify papilledema? That the margins of the optic disc are not defined, that is the stage 4. And this classification is known as, guys, this is known as the Keith-Wagner classification, guys. Okay, Keith-Wagner-Walker classification is the complete name of this classification, guys. Okay, see, now showing the findings like in the form of image, guys. See, I said there are 3 sides, so try to identify which one is artery, which one is vein, guys. Okay, so see, if you see here, guys, what happens, guys, here venous crossing, you see artery, and the ones which are darker are the veins, guys, and the lighter ones, smaller one, are the artery, guys. Do you see there is a crossing, guys? So this is AV crossing, guys. Okay, now see, what are the findings that you see here? Okay, when you think about the findings, see, there is a crossing, guys. Okay, now see, there is Salu sign, guys. So Salu sign, what happens? There is a deflection of the vein, guys, S-shaped deflection, remember, at the AV junction. See, this is a Salu sign. Do you see the S-shaped deflection, guys? Okay, now coming to the bonnet sign, guys. Okay, so when there is a bonnet sign, guys, okay, so what happens in bonnet sign, if you see here, guys, so it looks slightly more enlarged, guys, compared to the lumen here, guys. Okay, do you see the difference in the lumen, guys? So this is bonnet, means the bada, that is banking of the vein, that is distal banking, bada, distal to the AV crossing, guys, or the dilation of the vein. Now, guys, coming on to the gun sign, guys. So what happens in the gun sign, guys? It goes gayab, guys. Remember, like gayab. Okay, so what happens, like their vein goes gayab, guys. Okay, so it looks like vein is gayab, guys. If you see here bonnet sign, guys, I'll show you the bonnet sign. See, if you see the bonnet sign here, it looks gayab. Sorry, 1 minute, guys. See, it does not, it looks like it has gone emptied, it is hidden, guys. That is, guys, the gun sign, guys. Okay, see, so I said about the classification, that is Keith-Wagner-Becker classification, guys. I have already discussed. I have discussed in grade 4, there is silver wiring, there is edema, there is papilledema, and there is macular star, guys. Okay, so we need to know what are the differential diagnosis for macular star. That is hypertensive retinopathy, pregnancy-induced hypertensive retinopathy, and neuroretinitis, guys. Okay, so in hypertensive retinopathy, what did you find? You find the flame-shaped hemorrhage, you find the cotton wool spots, and you find the hard exudates, guys. Okay, see, so so this was about, guys, findings of hypertensive retinopathy. Now coming on to the findings of, guys, diabetic retinopathy. Okay, see, before telling you the findings of diabetic retinopathy, I would like to tell about the pathogenesis, guys. Okay, so what happens in diabetes, guys? You know, when there is a diabetes, there is less of insulin in the body, so there is hyperglycemia in the body. So what happens? This hyperglycemia, continuous high rise of glucose, guys, this causes microangiopathy, guys, echo and macroangiopathy. So we'll talk about the microangiopathy here. So when there is microangiopathy, guys, okay, it will involve the nerve, that is neuropathy. It will involve the retina, that is retinopathy, and also it can cause nephropathy, guys. Okay, so we are talking here about the retinopathy, guys. Okay, because our topic is the eye today. Okay, see what happens when there is diabetes, guys. So mechanism of sorbitol increases. So this sorbitol, when the sorbitol is high, guys, it damages the blood brain barrier, guys. Okay, so when there is damage, guys, this causes microaneurysm, guys. Okay, hard exudates, soft exudates, this causes microaneurysm, guys. This causes soft exudates, also known as cotton wool spots, guys. Okay, see, after all of this, guys, what happens? There is the ischemia. So when there is ischemia, means there is less of blood. So hypoxia promotes the secretion of chemotactic factor. So what are the chemotactic factors that are separated? They are known as vascular endothelial growth factor, guys. So what happens? This will promote angiogenesis, guys. When it promote angiogenesis, guys, new blood vessels are formed that will be leaky, guys. Okay, so this leaky blood vessels and neovascularization. Okay, so this can lead to certain complication. What can be complication? There may be vitreous hemorrhage, guys. There may be due to neovascularization glaucoma, known as neovascular glaucoma or 100 or 90-day glaucoma, and there may be tractional retinal detachment due to formation of tractional band, guys. Okay, see, now we'll talk about diabetes mellitus. Okay, so see what happens in diabetes mellitus. If you have a type 1 diabetes mellitus, that is insulin dependent and non-insulin dependent. Type 1, checkup after 5 years, guys. Okay, and if you have a type 2 diabetes, get checked up immediately, guys. Okay, then there is a term known as severe and very non-severe, guys, non-proliferative diabetic retinopathy, guys. Okay, so there is a rule, guys. Okay, that is 4-2 ka 1 rule. So 4-2 ka 1 rule is, guys, if there is a severe hemorrhage, okay, in all 4 quadrant, guys, or microaneurysm. 2 is, guys, if there is a venous bleeding in 2 quadrant, and 1 is, guys, if there is a IRMA in 1 quadrant. IRMA is infraretinal microvascular anomaly. If any one of these is present, guys, that is known as severe NPDR, and very severe NPDR if any 2 is present, that is very severe, guys. Okay, that is very severe. Okay, see, so basically this is the photo showing the non-proliferative. You can see the new formed blood vessels, guys. Do you see it appears more red, guys, while it appears less red? Okay, so see, this microaneurysm are the main finding, guys, here. Okay, so when there is a formation of new blood vessel, guys, that is known as neovascularization. It can take place at the disc, that is known as NVD, and NV that if it takes elsewhere, guys. Okay, and what are the complications of diabetes if it can be asked? It can be vitreous hemorrhage, tractional retinal detachment, and neovascular glaucoma. Okay, so see, I said there is an increase in VEGF, so we should give a drug that targets VEGF, anti-VEGF drug. So there is bevacizumab and you have ranibizumab, guys. Okay, that is bevafarani. You give bevafarani in order to control the treatment. Okay, guys. See, so this is a mnemonic how to remember which layer of retina is involved in what, guys. If you talk about microaneurysm, okay, so this involves the inner nuclear layer, remember main. If you talk about the hard exudate, guys, remember HOP. Okay, so this hard exudates, it involves the outer plexiform layer, guys. Now if you talk about the, guys, soft exudates, also known as cotton wool, remember CON, that it involves the retinal nerve fiber layer, guys. Okay, so hope this helps you to remember like which layer is involved. This may be asked in the form of MCQ, guys. This is very important. Okay, so do see once, guys. Okay, do not leave it. See, now coming on, guys, to this photo, you can see, guys, that optic disc is fine, but there looks very new the blood vessel, guys, at the optic disc, and there is a boat shape, guys. Okay, so this means there is neovascularization of the disc, guys, because the new blood vessels are formed. Okay, I said NVD and NVE, guys. Okay, so here the tortuous blood vessels are seen at the disc, means neovascularization has taken place. When neovascularization has taken place, guys, I said that what happens, what are the complications it can cause? It can cause vitreous hemorrhage, guys. Dusra, it can cause tractional retinal detachment, guys, and also it can cause neovascular glaucoma. So what happens here is the vitreous hemorrhage, guys. Okay, so it has caused a complication of vitreous hemorrhage. Then this is important from MCQ aspect. What is the most common cause of vitreous hemorrhage? In young person it is the Ills disease, guys, and in elderly it is proliferative diabetic retinopathy is the most common cause. I said this proliferative diabetic retinopathy will be this proliferative diabetic retinopathy has a complication. This forms, guys, vitreous hemorrhage it can cause. Okay, guys, see, so this is basically diabetic retinopathy. See, this is microaneurysm, okay, like very thin red dots, guys, that you see. Okay, so this is seen in inner nuclear layer. Then cotton wool spot, because it is indistinct, guys. See, margins are not well defined. That is in retinal nerve fiber layer. Then you have hard exudates, well defined margin wala, guys. Okay, that is seen in HOP, outer plexiform layer. Then you see the dot and blot hemorrhage, guys. Okay, so this was about the fundus finding in diabetic retinopathy, guys. Okay, see, now coming on to the retinitis pigmentosa, guys. Okay, so how do you remember the fundus finding in retinitis pigmentosa, guys? Okay, see, this retinitis pigmentosa, what does name suggest you? That there is a formation of a pigment. Okay, so see, this pigmentation, they are referred to as, guys, the bony spicules, guys. Okay, so these pigments are referred to as the bony spicules that you see here, guys. Okay, so this black pigment, the black bony corpuscline, okay, so these are basically the degenerated rods, guys. Okay, so rods are degenerated means there is a problem with the dim light, guys. Okay, so you will find problem with the dim light. Okay, see, now see, there is absence of fundal glow, guys, here. Okay, there is no fundal glow. Normally I said na fovea reflex is present, means there is some of the problem in the vitreous or somewhere else, guys. Okay, see, now coming on to the next finding, guys. Okay, and there is waxy pallor of the optic disc. So next finding is a bullseye maculopathy, guys. You can see it looks like a double layer, like a macula, bullseye, like a target it looks, guys. Don't you feel like it looks like a target, guys? Like Arjun ki machli ki aankh ko bhedna, guys, something like this. So this is found in chloroquine and hydroxychloroquine toxicity, guys. Okay, and congenital if there is deficiency of cone. Now coming on to the next one, that is Roth spot. Remember, guys, where do we see the Roth spot? It is seen in infective endocarditis, guys, when we talk about the John's criteria, guys. Okay, see what happens here, guys. So when you see here, guys, okay, there is retinal hemorrhage, but the inside the center, if you see, that is pale, guys. Do you see? This is pale center, whitish dot in the center. Okay, there is central pallor, that is actually the fibrin clot, guys. Okay, so this was the finding in Roth spot infective endocarditis wala. Okay, guys, see, now you see this photo, guys. What do you see? Again, you see, do you find a similar finding that it's pale inside in the center, guys? Roth spot, that is not specific, guys. It may be seen in infective endocarditis or maybe some other hemorrhage, guys. Okay, so see, this is basically red colored hemorrhage with white center, guys. That is infective endocarditis. See, this is again the similar finding, guys. Okay, see, then talking about the types of the retinal detachment, guys. I said there are three types of retinal detachment. Okay, guys, that is the rhegmatous retinal detachment, guys, tractional retinal detachment, and the serous or the exudative retinal detachment, guys. Rhegma means there is a break, guys. So there is a break in the layer, guys. Okay, so what happens? This liquefied vitreous will go to the subretinal space, guys. Okay, and there will be space inside it, guys. Okay, see, so when this goes inside, guys, okay, so see, what are the findings that you will see, guys, here? Okay, so basically what do you see here? You see the presence of, guys, in the vitreous, you see, guys, tobacco dusting sign, guys. Okay, tobacco dusting sign is seen here, guys. Okay, in rhegmatous retinal detachment. Okay, if you talk about the exudative retinal detachment, guys, okay, so this exudative or serous, what happens? There is basically the accumulation of the fluid here in the space, guys. Okay, so basically what do you see? The sign that you see is the shifting fluid sign, because there is a fluid that is it, so that is volume and gravity dependent, guys. Okay, and this both have convex border, guys. Okay, while this traction, when you put the force and pull, guys, that is concave border, guys. Okay, so there is concave border, guys. Okay, and the underlying retina is immobile, guys. Okay, see, so this were the findings of this were retinal detachment, guys. Okay, so this was all about the retinal detachment. Now see this photo. What do you see? There is a crescent or horseshoe shaped tear, guys. This horseshoe shaped tear, guys, is a classical finding, and that appears red in color. This is a classical finding of rhegmatous retinal detachment, guys. See, rhegmatous, also known as primary retinal detachment. Okay, this is due to the break in the retina, guys. Okay, so the fluid seeps inside, and it separates neurosensory retina from the retinal pigment epithelium, guys. Okay, so see, now coming on to the other findings, right? That is cystoid macular edema, known as CME, guys. Okay, then coming on to the, guys, central serous retinopathy, that is CSR, guys. Okay, and you have the best disease, guys. Okay, So what are the findings in cystoid macular edema, guys, and the other topics that we have not yet discussed, guys. Okay, so if you talk about, guys, about the cystoid macular edema, guys. Okay, so what happens in cystoid macular edema is that, guys, so there is the accumulation of fluid, guys, in the macula, guys. Okay, so when there is accumulation of fluid in the macula, guys, okay, there is accumulation of fluid in the cystoid space, guys. Okay, in the plexiform Henle's layer, or the outer plexiform layer is also known as Henle layer, guys. Okay, so when you do the, what is the investigation of size? When you do a fundus fluorescein angiography, okay, and optical coherence tomography is the investigation of choice, guys. Okay, so what do you see in optical coherence tomography, guys? You see the flower petal appearance, guys. Okay, and on ophthalmology, it's like a honeycomb appearance, guys. Okay, so this is very important from MCQ, that is flower petal appearance, that is CME. Okay, so basically, see, you might have heard in your college that you have conference in medical education, like a medical education in your college, guys. Okay, so when there is a conference of medical education in your college, the dignitaries that come, you present them a bouquet or a flower, guys. Okay, so that is basically the flower petal appearance. Okay, then the next topic is the central serous retinopathy, guys. So what happens that there is a serous detachment of the neurosensory retina, guys, at the macula. Okay, so here also the fluid leaks into the subretinal space, guys. So when you see the optical coherence tomography, guys, what do you see? There is a enlarging dot sign, guys. There is a ink blot or the mushroom sign, guys. See, first, second, and you have a smokestack appearance, guys. Okay, so this is the finding of, guys, these are the findings of central serous retinopathy, guys. Okay, see, now talking about the best disease, guys. Okay, so this best disease is autosomal dominant, that is bad, guys. Okay, and there is a VMP2 gene mutation, guys. Okay, and this codes for chloride sensitive ion channel. Okay, so what happens, guys, here fundus, what does it? So it shows like a egg yolk appearance, or a scrambled egg, or a pseudo hypopion sign. You might have remembered in your when you talk about the bacterial infection and all, there is a hypopion at the end that looks yellow in color. I'll show you the image for the, guys. So that looks like a scrambled egg, pseudo hypopion, or egg yolk appearance, guys. Okay, see, now this is the morning glory appearance of the fundus, guys. So this is a congenital optic disc anomaly, guys. Okay, so what happens, there is an abnormal closure of the embryonic freezer, okay, and the herniation of the disc, guys. So this is a very different finding, guys. It looks like someone is trying to escape and someone is trying to hold him back. So this is basically a congenital anomaly. It could not grow. So this is basically the morning glory fundus. When you are trying to wake up from the bed, but you cannot wake up, you feel like sleeping more, that is morning glory fundus, guys. Okay, see, now I'll talk about like in the form of a differentials. Like if a question is of red eye, what are the things that you should think of, guys, and how can you easily identify like what is the finding, guys. Okay, so this will make it more easy, guys, and you can hope you can remember it for a longer time, guys. Okay, see, first of all, I said I have showed the 3 photo of the congestion, guys. That is ciliary congestion, guys. Okay, ciliary congestion is basically around it, guys, that you see. Okay, that is circumcorneal or limbal congestion. Circumcorneal means around the limbus, guys. Okay, then generalize, all around it appears red, guys. Then is the sectoral a particular sector appears red, guys. Okay, so see, when you talk about the ciliary congestion, guys, so this happens in pathology, like when there is a corneal pathology, or when you have conjunctiva and other thing, guys. Okay, when you have uveitis, guys. Okay, when you talk about the generalized congestion, guys, that is seen in conjunctivitis. Okay, then diffuse scleritis or episcleritis. Then there is sectoral redness. Sector is involved, guys, that is pterygium. Okay, so what is pterygium? Pterygium is a wing-like fold, guys, of the conjunctiva. Okay, so basically that is pterygium. Or when there is a nodular or focal scleritis. Okay, when a part is involved, guys. Okay, see, until and unless, guys, this center part is involved, guys. Okay, until and unless visual axis is affected, guys, vision won't be affected, guys. Unless and until we say pterygium is only basically a cosmetic problem, it does not cause problem until it encroaches the visual axis of the eyes, guys. Okay, so then it creates a problem, guys. Okay, see, I'll talk about, first I'll talk about, guys, about the trachoma, guys. Okay, so this trachoma, okay, this trachoma is caused by, guys, chlamydia trachomatis. Okay, guys, so this chlamydia trachomatis, what are the serotypes that is caused? A, B, BA and C. Okay, how does it spread, guys? With 3F, that is finger, flies and fomites, guys. Okay, see, what are the important thing that you need to remember for trachoma, guys? So for trachoma, you have a classification by WHO that is known as the Fisto classification, guys. So what is this Fisto, guys? F is for, guys, follicle stage. I is for inflammation stage. S for scarring stage. T for trichiasis, guys, that is misdirected ileus, guys. Okay, and O is for opacity, guys. So this is basically the Fisto classification of trachoma, guys. Okay, now when we talk about the findings of trachoma, guys, okay, what do we see? We see the presence of tylosis, that is thickening of the lid margin, guys. Okay, we may see the madarosis, that is loss of, guys, eyelashes. Okay, then Herbert pits are seen in the corneas. This Herbert pits, see, they are basically around the limbus, guys. Okay, you see the pitting appearance, guys. Okay, I'll show you the photo further, guys. That is basically the Herbert pit, guys. Okay, now coming on to what is the treatment of this trachoma, guys. Okay, so the treatment, that is drug of choice, guys, is the azithromycin here, guys. Okay, so azithromycin is the drug of choice, but if like it has gone to trichiasis stage, that is Fisto, then you need to surgically correct it, guys. Okay, so basically what you can do either a surgery or you can remove that eyelashes, that is known as epiliation, guys. Okay, and you have a strategy that you remembered in your comment exam. What is the strategy, guys? That is WHO safe strategy, guys. Okay, so this topic is basically in comment also, guys, so I'm trying to inculcate that also, guys. Okay, S is for surgery. Okay, that is tertiary prevention, guys. A is for antibiotics, guys, that is secondary prevention. F is for facial cleanness. You are trying to clean so that you do not get the infection, that is actually the primary prevention. E is for environmental clean, means before the disease arises, you are trying to clean the environment only, guys, that is primordial prevention, guys. Okay, so this involves all tertiary, primary, secondary and primordial prevention, guys. Okay, see, now coming on to the first case, guys, you look at the photo, guys. There is a 23-year-old female, guys. Okay, and what are the findings? Bilateral, guys, non-painful eyes. Okay, red. Okay, red, you can see the eyes appear red, and it is non-painful, guys. Okay, and see, when you see visual acuity is fine, guys, 6/6, that is normal, guys. Okay, but she has a palpable preauricular lymph node, guys. What does it suggest to you? This suggests to us that this is a case of, guys, viral conjunctivitis that is caused, guys, due to adenovirus serotype 3, 4 and 7, guys. Okay, so basically this is actually acute follicular conjunctivitis, guys. You can say this is a very short history, guys. Okay, and how do you treat it? It is a self-limiting condition, guys. It will get corrected, guys. See, then you have other type of viral conjunctivitis that is known as epidemic keratoconjunctivitis, guys. Okay, so this epidemic keratoconjunctivitis, this is important from MCQ, guys. Okay, this is caused by adenovirus and serotypes, guys, 8 and 19, that is 8 plus 1 is 9, guys. Okay, that is 8 and 19. This is important, guys, from your MCQ aspect. Okay, see, now think about the next case, guys. This is a 12-year-old boy. See, that was a female, here a boy. He had a history of itchy eyes, bilateral, stingy, ropey discharge. Okay, asthma and allergy history also they have given. Also they have given conjunctival congestion, guys. See, when they give you the allergy history, guys, okay, and there is a boy of the age, guys, 5 to 14 year, guys, and there is a history of allergy in the family, then it is, guys, a vernal conjunctivitis or keratoconjunctivitis or the allergic conjunctivitis, also known as the spring catara, guys. Okay, so this is important from the MCQ aspect, guys. Okay, so what are the findings that you see? There is a stringy or the ropey discharge, guys. Okay, and when you look at the upper, guys, okay, so basically what do you see here, guys? There is papillae on the upper palpebral conjunctiva. This is basically the presence of papillae. Okay, so you need to know the difference between, what is the difference between papillae and what is the difference between the follicles, guys. Okay, so see, this papillae, okay, they are basically the flat topped elevation, guys, due to epithelial hyperplasia. Okay, so basically there is epithelial hyperplasia, guys. Okay, so what happens, this papillae, they contain a blood vessels at the center. You can see the image here, guys. There is a blood vessel at the center in the papillae, guys. Okay, so this is seen basically in some forms of allergic conjunctivitis, guys. Okay, now if you talk about, guys, about the follicles, basically, okay, so these follicles are lymphoid hyperplasia. Remember, follicles are lymphoid hyperplasia. And where do you find the follicles? They are found in the adenoid layer of the conjunctiva. Okay, in the conjunctiva adenoid layer. Okay, so they are white to gray elevation, guys. Elevations are here also there, but it looks more pale, guys, and center has Leber cells which are surrounded by lymphocyte, guys. Okay, so this is important, guys. Okay, See, now coming on to the next case, guys. Okay, there what does it? There is a copious discharge, okay, and there is vaginal discharge. Means when the child was born, after that he had a discharge coming from the eye. Means there is a bacterial conjunctivitis, and basically it is in the neonate, hence known as ophthalmia neonatorum. What is the cause, guys? It may be either due to Neisseria gonorrhoeae, or maybe, guys, due to the chlamydia trachomatis, guys. Okay, so this ophthalmia neonatorum, most common cause, guys, is the chlamydia. Okay, but most serious cause, guys, most serious blinding cause, guys, is the gonorrhea, guys. Okay, Neisseria gonorrhoeae. Okay, so see, what do you find a typical history? That there is a history of vaginal discharge. Okay, and the means there was infection in the mother, guys. Okay, so basically the person has a purulent discharge, guys. Okay, so how do you manage this case, guys? Okay, so you will take a swab for culture and sensitivity, guys. Okay, and you will use treatment option like, guys, tetracycline or erythromycin, broad spectrum like tetracycline, erythromycin, guys. Okay, will be used for the treatment of ophthalmia neonatorum, guys. Okay, now coming on, guys, to the next case, guys. Okay, so if you see this case, guys, what do you see here, guys? When you look at the photo, guys, see, I am covering the photo also, guys. So this was the presence of, guys, papillae on the upper conjunctiva. This is basically, guys, the papillae, and these are basically the follicles, guys. Okay, see, now when you think about the other things, guys, other question. Okay, so first of all, guys, we'll read the question, then we'll see what are the findings that you can expect in this question, guys. Okay, see, so there is a 20-year-old female, guys, okay, who is a contact lens user, guys. Okay, she presents with pain, redness, photophobia, PPR. Okay, and she admits using her friend's contact lens for using a wedding, guys. Okay, so if you use a contact lens, guys, okay, so there are chances of the infection getting transmitted, guys. Okay, so see, when you think about the contact lens, either it may be due to bacterial cause or maybe due to the fungal cause. Okay, so if you talk about the bacterial, guys, that is due to Pseudomonas, guys. If you talk about the fungal cause, guys, that is due to filamentous or the non-filamentous fungi, guys. Okay, if you talk about the protozoal cause, that is due to acanthamoeba. Okay, so see, what is the classical history that you need to ask? If there is a bacterial cause, guys, okay, so basically that there will be dry eyes, go. Okay, if there is a fungal cause, guys, think about the trauma with the vegetative matter, guys. Okay, and this protozoal cause when you clean the contact lens with the swimming water, guys, and virus when you have a history of immunosuppression, guys. Okay, so this will help you to identify, guys, what is the cause. Okay, and then treatment. If it is a bacterial cause, broad spectrum antibiotic. Viral cause, give viral drugs like acyclovir and other things, guys. Okay, so see, this was basically a photo of keratitis, corneal ulcer, and you had a hypopion. Okay, this was a hypopion, that is pus filled, guys. Okay, see, now coming on to the next one, guys. Okay, see, there is again unilateral painful red eye, and there is a recent history of chemotherapy for breast cancer, guys. Okay, and what do you see here, guys? You see that basically there is a dendritic pattern, guys. Okay, and there is basically, guys, knobs at the ends, guys. Okay, so if you have a knob at the end, guys, okay, so that is HSV keratitis, guys. Okay, see, etiology is herpes simplex virus 1, guys. Okay, so what happens, guys? There is a recent immunosuppression or illness. You can find there is a recent history of breast cancer and the patient is on chemotherapy, guys. Okay, guys, and management drugs like acyclovir or valacyclovir, guys. Okay, that makes it simple. Now see next question, guys. What happened? This is a case of, guys, sectoral redness. Means it's mostly due to scleritis or episcleritis, something like this, guys. Okay, see, there is a sectoral redness and visual acuity is normal, guys. Okay, see, when you have scleral infection, it may be episcleritis or it may be, guys, scleritis. Okay, so what do you find, guys, in scleritis? What do you find in sclera, guys, and what do you find, guys, there? Okay, so when we talk about, guys, scleritis, okay, guys, so see, when you talk about the episcleritis, guys, it may be either diffuse episcleritis or maybe nodular episcleritis. In scleritis, it may be either anterior or posterior. The most important thing, guys, is this, the necrotizing scleritis without inflammation. This is known as, guys, scleromatia perforans, guys. Okay, so this is important, guys, from MCQ aspect, guys. Okay, rest none of the things are so important, guys, here. Okay, so see, basically this may be associated with autoimmune disease or may be associated with connective tissue disease. Okay, guys, so there is a unilateral redness, we said, and what is the treatment? Systemic NSAIDs in scleritis and topical NSAIDs in episcleritis, guys. Now see this case, guys. Okay, there is a redness, okay, photophobia vision. Okay, and what is this diagnosis is the acute angle closure glaucoma, guys. Okay, so acute angle closure glaucoma, what happens, guys? Basically there is a shallow anterior chamber in the eyes, guys. Okay, and there is a pupillary block, guys. Okay, so there is a unilateral ciliary congestion. Okay, and their intraocular pressure would be high in glaucoma, guys. That is the main characteristic finding of glaucoma, guys. Okay, and treatment, you will give anti-glaucoma drugs, guys. You can do a iridotomy, make a opening in the iris, guys, so as to relieve the pressure, guys. Okay, so this is basically done in glaucoma, guys. Okay, see, now coming on the next one, guys. What do you see? You see the presence of, guys, here there is flare, aqueous flare and aqueous cells are seen, guys. Okay, see, IOP is high, IOP is the, okay, guys. So basically this is a case of uveitis, guys. Okay, so there is a history of immunocompromised or malignancy, guys. Okay, and how do you treat it? You will give steroids, cycloplegic and immunomodulators, guys. Okay, this is fine. So there is anterior uveitis, intermediate uveitis, guys, and the posterior uveitis. Okay, so see, basically uveitis, what does it will cause? It will cause eye redness, blurring of vision and flutters in the eye, guys. Okay, treatment, steroids, antibiotics, guys. Okay, see that terms iritis, that is inflammation of the iris, guys, that is associated with autoimmune disease like rheumatoid arthritis. Cyclitis, when the ciliary body is involved, you say an iris, ciliary body and the choroid. If it involves the choroid, that is known as choroiditis, guys. Okay, see this next case. This is an important case, guys. Okay, a 60-year-old patient 5 days post surgery present with redness, pain and decreased vision. So what is that? So basically this case after surgery, that is basically the end ophthalmitis, guys. Okay, that is the inflammation of the internal course of the eye, guys. Okay, so basically the most common cause is the staphylococcus epidermidis, that is the Coagulase negative, guys. Okay, and there is a history of reduced pain post cataract surgery, guys, and basically this is an emergency condition, guys. Okay, and the treatment is pars plana with or without vitrectomy, guys. Okay, now coming on to the next one, guys. Okay, so this basically that is, guys, that is the hordeolum, guys. Okay, so see, it looks like a painful condition, that is the external hordeolum or the stye, guys. Okay, this external hordeolum is also known as stye, guys. Okay, this internal, there may be internal hordeolum or maybe chalazion. See, this chalazion is basically a chronic condition, guys. Okay, it does not appear red, guys. Okay, there will be a thickening, but it will be away from the lid margin, guys. Okay, and what is the treatment? You do incision and curettage using the Clazion clamp, guys. Okay, so this is important from the MCQ aspect, guys. Okay, see, Clazion clamp. Okay, or here you can give, guys, treatment with antibiotics, guys. Okay, or a warm compress or something like this, guys. Okay, see, now just see the image and try to identify, guys. What does it look like? This looks like a splashed tomato appearance. No need to even look at the findings. So this is CRVO, guys, because there is a stasis of blood. What are the risk factors? Hypertension, and there is a sudden painless loss of vision. I discussed this, guys. Okay, there is a scattered hemorrhage in all 4 quadrants, guys. Remember what are the findings, guys, in central retinal vein, and there are cotton wool spots and macular edema you can find, guys. Okay, and what is the treatment, guys? So basically what you will do, you will give anti-VEGF drug like bevacizumab and ranibizumab, guys, bevacizumab. And if there is neovascularization, new vessels are formed, you will do pan-retinal photocoagulation. Why? Because it converts hypoxia to anoxia. Hypoxia is the cause that produces VEGF, so we will block hypoxia, so we will do pan-retinal photocoagulation. Now see, branch retinal vein occlusion, guys. What happens here, guys? That a small segment is involved, guys, not the entire retina is involved, guys. Okay, see, so basically I said about the VEGF drug, guys. Okay, and why it is given VEGF drug, guys. Okay, see, pan-retinal photocoagulation also, guys, we have discussed, guys. If there is a macular edema, go with anti-VEGF drug like bevacizumab. If there is neovascularization, go with pan-retinal photocoagulation, guys. Now see this photo, guys. There is a cherry red spot in the macula, guys, and there is a pale retina. No more confusion, guys. If you occlude the artery, less blood will go, guys. Okay, this makes it. See, risk factor are hypertension, diabetes, smoking. Okay, there is a cherry red spot, guys. Okay, so you are done with this, guys. Okay, see, now this is basically the branch retinal arterial occlusion. This is not important, guys. See, this image also we have discussed something like this, guys. You can see when there is a diabetes, it can lead to a complication known as vitreous hemorrhage. Remember we discussed 2 MCQ. Most common cause in child. What was the cause, guys? That was Ills disease. And most common cause in adult, remember guys, what was it? That was proliferative diabetic retinopathy, guys. Okay, so there is sudden painless loss of vision, guys. Okay, red reflex which you normally see is not present, guys, due to hemorrhage all around. It self resolves in 3 to 6 months, guys. Okay, otherwise it needs surgery, guys. Okay, see, now see this photo, guys. Okay, so basically this is, guys, diabetic retinopathy. So in diabetic retinopathy we see the presence of microaneurysm. See, this is small microaneurysm. You see the presence of cotton wool spots, guys. Do you see? Also, guys, you see the presence of hard exudates, guys. Okay, so basically what happens in diabetes? Again, there is hypoxia, ischemia that leads to VEGF. There may be proliferative and non-proliferative diabetic retinopathy, guys. Okay, so you find dot and blot hemorrhage, hard exudates and cotton wool spot, guys. Treatment: control the diabetes, guys. Okay, and you can give a pan-retinal photocoagulation for proliferative in order to convert hypoxia to anoxia, and anti-VEGF drug for macular edema, guys. Okay, so it's almost the similar treatment, guys. No confusion. Okay, now see the next question, guys. Okay, what happens, guys, here in this question? There is pain with ocular movement, guys. Okay, and there is RAPD, relative afferent pupillary defect, and fundus is normal, guys, if you see the image. Okay, so see, basically this is the optic neuritis. Basically the optic nerve has got involved, guys. Okay, so this, if anterior optic neuritis, it is known as papillitis, guys. Okay, so if you talk around, guys, if you talk about the optic nerve, guys. Okay, so talking about the optic nerve, guys, so basically here you can see the involvement of the optic nerve, guys, and there is guys, and there is pain and with the history of ocular movement, guys. Okay, so this is basically around about the optic neuritis, guys, and it self resolves after some time, guys, this optic neuritis. Okay, so what are the things that we need to know about the optic neuritis, guys? Okay, see, this optic neuritis, basically what happens, guys, there are 3 types, guys. Okay, that is retrobulbar neuritis. Okay, then, guys, you have papillitis, guys. Okay, and you have neuroretinitis, guys. Okay, see, what does name retrobulbar suggest you, guys? Okay, retrobulbar means it is the inflammation of the optic nerve behind the eyeball, guys. Okay, and this retrobulbar is the most common type, guys. Okay, and the most common cause of this is the multiple sclerosis, guys. Okay, remember this, guys. Now coming on to the papillitis. Papillitis means if only the optic disc is involved, guys. Okay, so this, when the optic disc is involved, it is known as papillitis, guys. Now coming on to the neuroretinitis, guys. Okay, so this neuroretinitis, guys. Okay, basically the neuroretina are the involved, guys. Okay, so basically this is the least common cause, guys. Okay, of optic neuritis, guys. So this is not so common, this neuroretinitis, guys. Okay, so what are the findings that you may see in this, guys? Okay, in retrobulbar neuritis, if you see, fundus findings are normal, guys. Okay, so basically most probably it would be a case of retrobulbar neuritis, guys. Okay, see, now if you think about the papillitis, guys, there is optic disc involvement, so there will be edema of optic disc, guys. There will be hyperemia of optic disc, guys, and there will be hemorrhage all around, guys. If you talk about the neuroretinitis, okay, so what happens in neuroretinitis? Optic disc is also involved, guys, and you have retinal exudation, guys, that are seen. Okay, so this is all about the, guys, about the optic neuritis, guys. Okay, so we have nothing other than this about the optic neuritis. Okay, now see this question, guys. Okay, so when you see this, there is a sudden painless loss of vision, guys. That is, patient is more than 70 years, guys. Okay, there is complaints of temporal headache. Okay, also claim that means pain while eating food, means she has jaw claudication pain also. More than 65 years, jaw claudication pain, and also blindness. That is giant cell arteritis, guys. Okay, so giant cell arteritis is a very important, guys, cause, guys. Okay, so basically if there is a ischemia of optic disc from the vasculitis, known as called arteritic anterior ischemic optic neuropathy, guys. So there is a sudden painless loss of vision, guys. There is a reduced vision, relative afferent pupillary defect with optic disc, guys. Okay, so this simplifies it, guys. Okay, treatment: emergency IV steroid, guys. Okay, and referral to the rheumat also, guys. Okay, now coming on to the next one. Do you see there is a break in the retina, guys? So no more thinking, this is a retinal detachment. There are 3 types: rhegmatous, exudative or serous. Tractional का cause proliferative diabetic retinopathy. Exudative का cause not very important. Rhegmatous का most common cause, that is myopia, guys, which we read. There were Laker cracks, there were rhegmatous retinal detachment, guys. Okay, see, what happens here, guys, the vision is reduced only if macula is involved, guys. Okay, and treatment we have done, we can go for vitrectomy or we can go for SF6 drugs, guys. Okay, now see, now talking about the next one, guys. Okay, there is a 70-year-old patient, guys, who has a loss of vision for last 2 years and known diabetic and hypertension, means age related changes, guys. There is a opacification of lens protein due to age, that due to sorbitol polyol pathway, okay, or trauma or steroid in this, guys. Okay, so there is a gradual loss of vision, painless, guys, and there is a opacification of lens. See the photo, guys, the lens looks so ossified, and you go for surgery, guys. Here, that is the main treatment choice. Okay, now see here what happens. The IOP is high, guys. Okay, and anterior segment is within the normal limit, guys. Okay, so basically this is basically a glaucoma, guys. Okay, so in glaucoma what happens, there may be open angle glaucoma, there may be close angle glaucoma. Open angle primary, that is primary open angle glaucoma. Secondary is due to uveitis or steroid induced glaucoma. Now coming on to the close angle, if it is due to lens induced, guys, that is secondary. If it is due primary, it is primary angle close angle glaucoma, guys. Okay, see, now coming on to the next one, guys, what do you see? IOP is 15, guys. Okay, and female smoker is there and reduction of vision is there. You see the presence of drusen, guys. Okay, if there is presence of drusen, that is basically ARMD, guys. Okay, chronic age related degeneration of the Bruch membrane, guys. Okay, and smoking is a risk factor, so the smoker was given in the history, guys. Stop smoking. If there is wet, okay, mode of proliferation, give anti-VEGF. If there is dry, give multivitamin tablet, guys. Okay, see, now coming on to the next one, guys, that is proptosis. Proptosis is basically the bulging of the eye, guys. Okay, the most common cause of unilateral and bilateral proptosis, for both the most important cause is the thyroid eye disease, guys. Also it may be due to trauma, orbital cellulitis, or maybe due to tumors like neuroblastoma, guys. Okay, see, next is also a case of proptosis. Okay, but there is a case of 8-year-old child. Okay, because of a 2 days history of swelling and redness. Okay, guys, so basically we need to know which is preseptal cellulitis or maybe it's orbital cellulitis. See, orbital cellulitis may have dysfunctional optic nerve test, proptosis, okay, extraocular movement restriction and chemosis, guys. Okay, but preseptal cellulitis does not have any of this feature, guys. Okay, see, next is a case of, guys, eye bulging with gritty sensation and a female. You know, females are more prone for thyroid eye disease. So basically this is a thyroid. So what happens, there is an antibody known as long acting thyroid stimulator. They stimulate the orbital fibroblast to differentiate, guys. Okay, and to produce more muscle fiber. Okay, and this leads to the bulging, guys. There is a gritty sensation, guys. Okay, and you have various eye signs and thyroid disease that you will read in the surgery, guys. Okay, now see the next one, guys. There is a 6-week-old child, guys. He's brought for routine eye checkup, and you will see that it looks white, guys. Okay, so this is known as basically leukorrhea, that is white pupil, guys. Okay, so what are the differential diagnosis of leukorrhea? Remember the mnemonic predict. Okay, doctor is predicting the future of child, guys. Okay, that is P is for PHPV, persistent hyperplastic primary vitreous, guys. R for retinoblastoma, retinopathy of prematurity. E for endophthalmitis, guys. D for dysplasia of the retina. I for inflammatory cyclitic membrane. C for congenital cataract or the Coats disease, guys, and T for toxocariasis, guys. Okay, so this is basically leukocoria. Now see, this is the next one, guys. Okay, if you see the image only, guys, that is when you lower down the eye on down gaze, guys, it becomes more prominent. This is known as the Munson sign, guys. Okay, so basically this Munson sign, guys, so you have corneal thinning with protrusion, guys. Okay, so this was Munson sign. Okay, see, so this is the rapid revision of events. We have done almost all the images, so we'll revise as quickly as possible, guys. Okay, see, there is a splash tomato appearance, entire fundus is scattered with PRAO. It appears the rods, guys, okay, and there is a deposition of pigment, guys, so there will be problem in dim light, guys, okay. Peripheral rods are affected first, guys, and this is a poor prognosis. See, this is a pale optic and there is a autosomal dominant pattern, guys, okay. So there are certain syndrome that are associated this WHO classification is also present for, guys, for the xerophthalmia, guys, okay. So that has classified the xerophthalmia, guys, okay. So how do we classify xerophthalmia, guys, according to the WHO classification, guys, okay. So we will be talking about that, okay. See, first of all, there is XN, guys, that stands for night blindness, okay. Now coming on to the next one, that is X1A, guys, okay, that is conjunctival gerosis, guys, okay. Then X1B, guys, B for Bitot spot, guys, okay. Now coming on to the X2, guys, okay. So we have gone to the conjunctival, so now it will be corneal gerosis, guys, okay. Now coming on to the X3A, okay. Then X3B, okay. X3A is, guys, corneal ulceration, okay. Now instead of gerosis, dryness, there will be ulceration, guys, in less than 1/3, guys. If it is more than 2/3, it is X3B, guys, okay. Now XS, that is corneal scar, guys. XS is scar, guys, okay. Then you have XF, that is xerophthalmic fundus, guys, okay. So this was about, guys, about the classification of this, okay. See, So this is basically pedicula, that you have a yellow nodule, guys. Okay, that is teresm. Now coming on to the keratoconus. So basically this is the corneal ectasia, guys. Okay, so when you look at the down gaze, it becomes excessively prominent, known as Bunsen sign. Then say you have a fleshing. So this is known as the Kessler fleshing. Basically what happens in Wilson's disease, so basically there is deposition of iron. Okay, sorry, this is Flesher's ring, guys. Sorry, this is seen in keratoconus. If you talk about the Kessler-Flesher ring, guys, that is seen in Wilson disease. Okay, so basically this is yellow brown to olive green ring, guys. Okay, we'll talk about the Kessler-Flesher also. See, this Kessler-Flesher ring is due to the copper deposition. Where does it deposit? In the Decimex membrane, guys. Okay, and how do you remember, guys? Wilson is which gene mutation? That is ATP7B. Remember B beta, that is sun, guys. Okay, there is also a known as ATP7A mutation, guys. That is seen in Menkes disease, guys. Do not get confused, guys. Okay, so see, this is a cataract, that is clouding of the lens, guys. Do you see? This is the star-shaped stellate cataract. Okay, see. Then you have Morgagnian cataract, guys. So what happens? See, you can see a demarcation that it has nucleus has shrunken down, okay, with liquefied cataract. And what is the complication, guys? So this will block it, and this is known as phacolytic glaucoma. Then you have the Christmas tree cataract, guys. Do you see? So basically Christmas tree cataract is seen in myotonic dystrophy, guys. And what is the trinucleotide repeat, guys? CTG. Now coming on to the senile nuclear cataract, that is basically seen as a result of old age, guys. Sunflower shaped cataract, Wilson. Remember sunflower, guys. Okay. Now coming on to the blue dot cataract, also known as punctuate cataract. This is the most common type of congenital cataract, guys. Okay. And there is multiple blue dots, guys. Do you see? Multiple blue dots seen around, guys. Okay. Then there is glaucoma, that is neovascular thinning, guys. Okay. So this is basically in glaucoma. Now so we'll talk about the most important one-liners in opthal, guys. Okay. The most important thing that may be asked as a one-liner. Okay. First of all, what is the total refractive power of the eye, guys? That is around 58 to 60 diameter. Out of which, guys, 3/4 is contributed by the cornea and 1/4, guys, by the lens. Okay. See, if you talk about the parts of a tear film, guys, there are 3 parts of a tear film. You have a lipid layer, aqueous layer, and you have a mucin layer, guys. Okay. So this lipid layer, guys, it is from the meibomian gland, guys. Okay. This aqueous layer is from the lacrimal gland. Okay, guys. And this mucin, which cells produce mucin? That is the goblet layer, guys. Okay. In the lids, there is the lipid layer, that is meibomian gland. And aqueous layer, lacrimal gland, tears gland. Okay. What is that? That is water actually when you cry, guys. Okay. See. What happens? This aqueous humor, it provides nutrition to the cornea and the lens. Why? Because the lens is avascular, guys. Okay. Now say, what is the normal intraocular pressure? That is 10 to 21 mmHg, guys. Okay, see, now testing for the various testing method, retinoscopy, what you will do to check for the refractive error. When you go and you place eye on the instrument, you might have seen, guys. Okay, then is the tonometry, guys. Why? To check the intraocular pressure, guys. Okay, then is the gonioscopy, to measure the angle of examine the angle of the anterior chamber, guys. You have the gonioscopy. You have certain structure that you can see through the gonioscopy, guys. I'll tell you further. Then ophthalmoscopy, I said indirect and direct, to look at the fundus. Okay, direct ophthalmoscope. Okay, so remember, direct was erect and virtual, guys, and it was 15 times magnified. Do you remember the mnemonic, guys? Central retina. Indirect is basically peripheral retina because it gives only a 5 times magnification, so you can look a long distance. Then is the pachymetry, guys. That is measurement of the corneal thickness, guys. Keratometry, when you measure the corneal curvature, guys. Okay. Then tomography, that the corneal surface, how is the curvature and the thickness, guys. Then you have the fundus fluorescein angiography. Okay, that we said that flower appearance in CME. Okay, so basically that is optical coherence tomography, guys, to study the disease of macula and the other things, guys. Okay, then you have electroretinography, guys. Okay, so basically investigation of choice in retinitis pigmentosa, guys. Okay, for best disease, guys, that was autosomal dominant. You remember, bad we remember, that is electrooculogram, guys. Perimetry, to look for the visual field, guys. Okay, to measure the axial length, you have biometry, guys, biometry. Okay, then you have the Schremer's test to look for the dry eye, guys. Okay, and you have for proptosis, you have a test known as Hertel's exophthalmometry, guys. Okay, exophthalmus, that is protrusion, guys, that is proptosis. Now coming on to the conjunctiva, remember, Horner-Tranter spot seen in vernal keratoconjunctivitis, also known as spring cataract. Cobblestone appearance seen in vernal keratoconjunctivitis. Ropey mucoid stringy discharge is seen in vernal keratoconjunctivitis. Sealed ulcer is also seen in vernal keratoconjunctivitis. This is important MCQ. Angular conjunctivitis is called by Moraxella axenfeld bacillus, guys. Epidemic keratoconjunctivitis is caused by adenovirus. Can you recall the serotype, guys? 8 and 19. Common cause of hemorrhagic conjunctivitis, that is echovirus, enterovirus, adenovirus, guys. See, this is important. Swimming pool conjunctivitis can be due to adenovirus or chlamydia trachomatis serotype D2K, that is known as inclusion conjunctivitis. Then filing tubular conjunctivitis, this is basically the reaction to the TB protein, guys. Okay, so there will be yellowish nodules and reaction to either TB or the staph protein, guys. Then say chlamydia trachomatis already done by serotype A, B, B and C. Then you have Hall-Burzker-Prozowski body. This I have done in detail about the pathological bodies in one of my video. Check it out, guys. The sago grain in trachoma we have discussed, guys. Herbert follicles and pit in trachoma, guys. We have taught. Als line is seen in trachoma, guys. This is important, guys. Fisto classification we said. Safe strategy we have already discussed, guys. Most common site of terathism, guys, nasal terathism is much more common because it receives the sunlight that goes there, it gets reflected most of them there only, guys. You have a Stocker's line, okay. See, Bittot's spot we talked about the deficiency and the classification of entire ophthalmology we have talked about, guys. Okay, see, most common association of scleritis, I said it's rheumatoid arthritis, already discussed. Scleromatia perforans, that was necrotizing without inflammation, we have already discussed in long standing rheumatoid arthritis. Okay, see, then we have discussed, guys, most common cause of bacterial ulcer in India is the pneumococcus. Okay, that also causes serpens ulcer, guys. Fungal ulcer, that is aspergillus, guys. Okay, see, ring ulcer in contact lens user, guys, that is acanthamoeba keratitis. And most common ulcer in contact lens user, that is the acanthamoeba keratitis. So this is very important, guys, for this respect. Okay, see, painful ulcer is the protozoal ulcer, that is acanthamoeba keratitis. Ulcer serpens we have already discussed due to pneumococcus. Hypopyon is a pus field, that is due to pneumococcus again, guys. There is multiple satellite nodules around the ulcer. Okay, that is due in the fungal corneal ulcer. You see multiple satellite nodule. Okay, and you have also there is a immune ring of Whistler, guys. Okay, in fungal corneal ulcer. Now dendritic ulcer I said in herpetic ulcer. In herpes there is a loss of sensation, guys. Okay, so that is herpetic ulcer. Geographic ulcer in again herpetic ulcer. Disciform keratitis, that is again, see, Hutchinson size, that is in herpes zoster virus ophthalmitica. If the tip is involved, guys, more chances of spread are there, guys. Okay, see, then we have salmon patch in interstitial keratitis, guys. Okay, then you have two ulcer, neurotrophic ulcer and neuroparalytic ulcer. So if there is paralysis, that is the facial nerve involved. Trophic is the panchwala nerve, that is the trigeminal nerve involved, guys. Flesh shedding, remember flesh shedding was in keratoconus, guys, but the Kesher flesh shedding was in Wilson disease, guys. Then Vox striae, you remember that is seen in keratoconus. Also Munson sign was seen in keratoconus, guys. Nerves were present in keratoconus and oil droplet reflex is present, guys. That is CONES, guys. Then there is Rizzuti sign, that is seizuring of the reflex, okay, in retinoscopy, guys. Okay, basically, so oil droplet reflex we said on keratoconus. Munson sign also we discussed, guys. Okay, see, investigation of choice for keratoconus, that it has turned more, so we need to go corneal tomography, guys. Okay, and C3R or collagen cross-linking treatment can be used, guys. Okay, see, and what is the most common stromal corneal dystrophy, guys? That is the lattice dystrophy, guys. And endothelial, guys, okay, that is the Fuch endothelial, that is FUC, Fuch endothelial dystrophy, guys. Okay, then guys, lens, most common type of congenital cataract we already discussed, that is the blue dot cataract. Most common type of visually significant, guys, then it is the lamellar or geminal cataract. See, most common type of acquired, that is due to age, guys, that is senile cataract. Index myopia, guys, okay, that is second side, means people who have a far glasses, guys, now they compare that after getting cataract, they are able to see nearby objects which they were previously not able to see, guys. That is only index myopia, guys. Okay, see, cataract causing glare or early vision disturbance, guys, that is the posterior subscapular cataract, PSC, is the most visually significant cataract. Affecting the difficulty in dim light. See, what happens in cuneiform cataract, there is the opacity in the periphery, guys. Okay, so what happens in dim light, guys? So there is means the pupil dilates more, so more of the light goes through the periphery, hence vision decrease. Most common complication of Morgagnian cataract, that is the phacolytic glaucoma, guys, because all the lens material have sunken down, guys. Phacomorphic glaucoma, guys, that is due to the intumescent mature cataract. So these are the very important thing, guys. That slow flake cataract in diabetes. Okay, then you have rosette cataract due to when you try to give a dose and she rejects you, that is a trauma in your life, that is blunt trauma. Old oil droplet cataract, that is galactosemia, guys. Okay, reversible cataract in galactosemia. Okay, so this is important. Which of the following cataracts is reversible? That is galactosemia. Sunflower, Wilson, sunflower. Christmas tree, myotonic dystrophy, that is CTG, guys. Then you have two things in complicated cataract. Okay, that is polychromatic luster and breadcrumb appearance, guys. Must know thing. Okay, see. Then then important is steroid induced cataract, that is posterior subscapular cataract. Anterior lenticonus is the Alport, and posterior is Lovis syndrome and Down syndrome, guys. Okay, this is important. Then microsphericchia. Okay, so the lens is small and more spherical, that is known as wheel Marchesani. Here basically a lens is anteriorly displaced, guys. Okay, then you have ectopia lentis, guys. Okay, ectopia lentis means lens is not in a normal position. The normal position of the lens, guys, in the patellar fossa, guys. Okay, so see, that is superotemporal. Okay, that is Marfan. Remember, where is the fan located? On the ceiling, guys. That is superior. Then inferonasal, homocystinuria. Where does urine go when you pee, guys? It goes down, guys. Urine. Okay, so that is inferonasal dislocation, guys. Okay, see, what is the laser used in cataract surgery, guys? That is the femtosecond laser. Ideal site in the capsular bag if you implant, guys. Okay, flexible is made, rigid is made of PMMA, that is polymethyl acrylate, guys. Okay, and what is the formula for IOL calculation? That is SRK formula. ठीक, that is power is equal to A minus 0.9K minus 2.5 L, guys. Okay, most common complication, guys, is the PCO, posterior capsular cataract or after cataract. Here you can see the presence of Elshing's pulse, guys. Okay, so this is important. Most common dangerous complication, I said you the endophthalmitis, and most common cause is the staph epidermidis, guys. Okay, see, if you talk about the early, this was acute onset. If there is late onset, guys, that is due to the propionibacterium acne. Treatment, you go for pars plana vitrectomy, guys. Okay, see, now coming on to the glaucoma. So gold standard is Goldman applanation tonometry, guys. Okay, there will be bionating of the vessels or nasalization of the disc on fundus finding, guys. Okay, see, there is a bearing of the blind spot, guys. There may be sedal scotoma, arcuate scotoma, ring scotoma, or Doenis nasal. Okay, guys, see, then surgery of choice for congenital glaucoma with clear cornea. If the cornea is clear, go for goniotomy. See, clear cornea, go for goniotomy. If there is a hazy cornea, you go for trabeculectomy. Okay. Then see, what is the laser used? There we had femtosecond laser in cataract. Here you have NDYZ laser, guys. Okay, see, then laser for open angle glaucoma, guys. Okay, angle was NDYZ, that is laser trabeculoplasty. Okay, guys, see, then now coming on to the important drugs that you need to know, guys. Okay, so what is the drug of choice for bacterial corneal ulcer, guys? So that is basically fortified cefazolin and fortified tobramycin. Okay, tobramycin is used for Pseudomonas infection, guys. Fungal corneal ulcer filamentous wala, you have nitamycin, guys. Acanthamoeba keratitis, you have, guys, propamidine, guys. Okay, then for herpetic corneal, herpes is acyclovir, guys, no confusion. Infective corneal ulcer, you will go steroid if it is infected, guys. Okay, all the drugs that are given, this is very important, drugs given in all infective, you will give cycloplegic, that is atropine, guys. First line of drug or anti-glaucoma drug of choice, that is prostaglandin analog. Okay, so prostaglandin, what is the example? That is letanoprost, travoprost and bimatoprost, all the prost wala prostaglandin, guys. Mechanism of action of prostaglandin, what does it do? It increases the uveoscleral outflow. Okay, but what is the problem of prostaglandin? That is prostaglandin causes dark iris, that is pigmentation. Prostaglandin causes pigmentation, guys. Okay, what are the drugs contraindicated in asthma, COPD, heart block? Basically the beta blockers. Okay, so they are contraindicated. Drugs contraindicated in children, that is brimonidine. Okay, drugs causing sleep apnea, guys. Okay, that is again the brimonidine. Okay, guys, see, drug of choice for acute angle closure glaucoma, guys, that is the pilocarpine, guys. Okay, see, then anti-glaucoma drug causing retinal detachment is again the, guys, pilocarpine, guys. Okay, so basically this is scrap of the retina. You can scrap carp, that is scrap, guys, that is retinal detachment. Okay, guys, see, then topical drug use, topical carbonic anhydrase inhibitor used in glaucoma, that is dorzolamide, guys, and brinzolamide, guys. Okay, most common side effect of acetazolamide, guys. Okay, that is paresthesia. Okay, and they are contraindicated in sulfur injury. Okay, fastest acting is the mannitol, guys. It will help you to reduce the pressure, guys. Okay, so see, This was all about the important one-liners, guys. We have mostly gone through all the images. See, this is a blue dot cataract, guys. This is a posterior polar cataract. This is a Christmas tree cataract. We talked about all the other cataract previously. Just try to identify. This is a nuclear cataract, guys. Most common in old age. Cuneiform cataract, where you have problem in the dim light and west-shaped opacity, guys. Here there is a posterior subscapular cataract, guys. This is the most common visually significant cataract. See, this is a snow, like a snow, that is in diabetes mellitus. This is a oil droplet cataract in galactosemia. So basically this is a sunflower shaped cataract, guys. Okay, that is seen in Wilson disease. See, there is a bulging of the lens. Do you see, guys? That is anterior lenticular seen in Alport syndrome. See, there is a bulging of the lens. Again, it is the same finding. Okay. See, then there is a bulging of the lens, guys. In this photo, there is a bulging of lens posteriorly, guys. That is posterior lenticonus seen in Dow and Lowy syndrome. See, there is a rose strip, that is trauma, blunt trauma. Then phacoemulsification is a technique of surgery, guys. So you have a lens that is anterior chamber IOL. If it is rigid, it is made up of PMMA, guys. And formula is P barabar A minus 0.9K minus 2.5L, guys. Okay, so this is an anterior chamber IOL implanted. This is a scleral fixated lens, not important so much. This is a Ilsing pulse. So this is seen in posterior capsular ossification, guys. Okay, so what is the typical history? There is a slow, painless decrease of vision after surgery, guys. See, there is a superotemporal dislocation. Remember, superior, what goes superior is the fan. That is the Marfan syndrome, guys. See, now coming on to the glaucoma. So this is basically congenital glaucoma. What do you see, guys? So basically congenital glaucoma, the differential diagnosis is, again, it comes in the predict mnemonic, guys. That is retinoblastoma, persistent hyperplastic and other things, guys. Okay. So this is a stereostonometer that is used to measure the intraocular pressure. Then this was a applanation tonometry, guys. This is more popular. Then nowadays we have gone to a more recent, that is the tonopen, guys. Okay. Then, guys, we have automated perimetry used to measure the visual field, guys. Okay, nasal, temporal and other field. This is a slit lamp biomicroscope, guys. Okay, see, this is an indirect ophthalmoscope. What we remember that this is 5 times magnified, guys. There is magnified image, and what happened, guys? There is real image. Okay, see. Now in direct ophthalmoscope, this is 15 times magnified. There is direct image and there is virtual image, guys. Okay, see. Now coming on to the next one, guys. Okay, so this is basically a similar photo. Then what are the structures that you can see, guys? Okay, so mnemonic is I can see till Swalb's line. Okay, I means iris root. Okay, C means ciliary body, S means scleral spur, T means trabecular meshwork, and S means Swalb's line, guys. Okay. So basically, see, this is the glaucoma finding, guys. Okay, there is lamellar dot sign, there is bionating sign. Okay, guys. Then coming on to the cornea, guys. So this is bacterial keratitis. You see the presence of hypopyon. So there may be history of contact lens user, and basically there is hypopyon here. Now coming on, guys, to the fungal keratitis. So I said history of trauma with organic material, guys, and treatment antifungal drug. And this, guys, is the hypopyon, guys. Okay, so then you have dendritic ulcer, guys. Okay, so there are terminal bulb and stains with fluorescent dye. If it enlarge, guys, it can form a geographic ulcer, guys. Okay, basically. Okay, treatment is acyclovir. Then this is the herpes zoster keratitis, guys. And if you find like coin-like appearance, that is known as nummular keratitis, guys. Okay, it develops within 50% of the patient. See, this is coin-like appearance, that is nummular keratitis. Then you have pseudodendrites of the herpes zoster, guys. Okay. See, now coming on to the acanthamoeba, most common cause in contact lens use, guys. So what you can find the perineural infiltrate, guys, and there may be ring abscess which may be asked in the form of a MCQ, guys. Then you have a salmon patch which may also be again found here, guys. Okay, see, then keratoconus, that there is a bulging of the lens, guys. Okay, so keratoconus, what do you see? Oil droplet reflex, Vox stria. You have Flesher ring, guys. Okay, Munson sign, bulging of lower lid on down gaze, and there is acute hydrops, guys. How do you remember? C for central scarring and Flesher ring. O for oil droplet reflex. N for nubs are prominent. E for excessive bulging on down gaze, known as Munson sign. S for stria Vox, guys. Then Arcus analis, seen in old age, more than 60 years of age, guys. Occasionally associated with hyperlipoproteinemia, means more lipids are there, guys. Then you have band-shaped keratopathy, seen in hypercalcemia, renal failure, sarcoidosis, anything that increases the calcium, guys. This is the band-shaped keratopathy, guys. Then is the cornea verticillata, guys. Okay, it is seen in certain drugs like amiodarone, chloroquine, and alpha-galactosidase, that is Fabry's disease. Okay. See, Kasher-Flesher ring is basically the deposit of the cornea and the basement membrane, and the mutation is ATP7B. So see, this is the scleromatia performance, that is necrotizing scleritis without inflammation, guys. Okay, and there will be history of rheumatoid arthritis in patient, guys. Then see, This is basically, what do you see? This is the membranous conjunctivitis. This is the hemorrhagic conjunctivitis due to adenovirus and echovirus. This is the follicles of the trachoma, safe strategy. Arch line seen in clavidia infection trachoma, guys. Okay, see, Herbert pit seen around the limbus in trachoma. Then filing tubular keratoconjunctivitis, guys. This is due to allergy to the TB or the staph protein. This is the cobblestone appearance of the papilla and vernal keratoconjunctivitis. That is Horner anti-spot. This is Biot's spot seen in cases of xerophthalmia vitamin A deficiency, guys. This is keratomalacia, guys. Okay. See, now this is a wing leg fold, that is sterism, guys. This is the rose Bengal stain that we have done to identify the problem. These are the tear strips in order to know whether they are dry eyes or not. Then coming to the lacrimal drainage system, this is a technique of decrocystography to know what is the problem, where is the problem, guys. Okay, that is. Then this is the mutton fat appearance, guys. Okay. So this is the snow banking appearance, guys. This is posterior uveitis known as choroiditis. Okay. So then you have candle wax dripping, that is typical of sarcoidosis, guys. Okay. We talked about the candle wax dripping. It looks like someone is firing in the sky. Okay. Headlight and fog appearance we talked about in toxoplasma, guys. Do you see? See. Then this is the salt pepper fundus, guys. Okay. Okay, in a patient with rubella, salt and pepper retinopathy, you remember. Then remember sauce and cheese retinopathy, that is in chalo molchale, that is cytomegalovirus, guys. Then guys, we talked about the papillitis where there is inflammation of the optic disc, guys. Okay, then we have the neuroretinitis, guys. Okay, that is the least common, and here you see the presence of a macular star in neuroretinitis, guys. Also in hypertensive retinopathy you may see macular star. This is the papilledema, guys, where there is entire optic disc is not well defined, guys. Okay, guys, see, now coming on, guys, to the this looks like a finding, guys, of consequent optic atrophy due to retinitis pigmentosa, guys. You can see the bony pigmented spicules of the retina, guys. Okay, so this is basically white, that is known as leukorrhea, that is mnemonic was PREDICT, guys. Okay, so see, this is basically retinoblastoma, guys. Okay, then guys, coming on to the poliosis, that is there is whitening of the eyebrows, guys. Then madarosis means the loss, guys. See, you can see there is a loss, guys. Okay, then trichiasis, that is misdirected, guys. That may occur in Fisto classification. Tylosis, that is, guys, thickening. Okay, see, then sty is the external hodiolam, guys, and chalazion. Okay, so this is a chronic inflammation, and here the treatment is using the incision, and ptosis is the drooping of the eyelids, guys. Okay. See, now after ptosis, guys, so this was all about the ptosis. So see, now coming on to the important fundus image. This is diabetic retinopathy, guys. We have already discussed, guys. Okay, see, hypertensive retinopathy, grade 4 discuss. Splash sauce appearance or tomato, that is CRVO, guys. Cherry red spot, CRAO. Retinitis pigmentosa, bony pigmented spicule. Best disease, guys. This is a photo of best disease. Okay, guys, where in the macula you see the presence. Okay, okay. Now see, Pushner retinopathy, that was grade 4, and you have cotton wool spots all around, guys. Okay, bullseye maculopathy, like a target, guys, that was due to chloroquine drug induced, guys. Okay, CQ drug. Okay, then you have the pathological myopia, you have lacquer cracks and other finding, guys. This is the lattice degeneration again, guys. Okay, and you may have the regmatous retinal detachment. So all these are the findings of myopia only, guys. Okay, so see, so basically this was all the findings of myopia. This was the Drusen's disease that causes, guys, dry ARMD, guys. Okay, see, now coming on to the other finding that we see, we talked about, guys, the cystoid serous retinopathy, that is ink blot pattern, guys, and we talked about the smoke stake appearance. See, guys, when you talk about the ink blot, looks like ink from a pen has leaked out, and it looks like smoke all around, guys. Okay, see, when you talk about the CME, that is you give a flower, that is flower petal appearance. Do you see the typical flower pattern appearance in cystoid?